I have had countless patients tell me they've tried physical therapy and that it didn't work for them. However, the vast majority of these patients didn't truly fail physical therapy. How can that be? Well, in today's video, we're going to talk all about that, so let's get started. Welcome back, everybody, to the Building Lifelong Athletes podcast. Thanks so much for stopping by. I really appreciate it. For those who don't know me yet, my name is Rennicke, and I'm a dual board certified physician in family and sports medicine. And the goal of this podcast is to help keep you active and healthy for life through actionable evidence-informed education. Today, we're talking all about physical therapy and how to evaluate if someone's actually had a true physical therapy course and how to troubleshoot with someone who hasn't had success they were hoping for. So let's get started. Okay, so the first thing I want to talk about is what actually is a physical therapist. And so physical therapy is kind of like this black mystery box to so many people, including physicians. I mean, I can't tell you how many of my colleagues don't quite understand what physical therapists do. They just put in referrals to physical therapy and then just okay, they'll take care of it. And so I'm just trying to set things straight here to say, hey, all right, let's talk about what physical therapy is, what they do, what's their educational background so we can understand what's going on. So physical therapists today now have a doctorate level degree in their field. So back in the day, it used to be a master's level, but now today, pretty much every school has a DPT or doctorate of physical therapy. So they are doctorate level in their field. And they are experts in assessing, diagnosing, and rehabilitating musculoskeletal and nerve issues. And so this is what they go to school for. Obviously, they have lots of different rotations. They have clinical rotations. They go through inpatient, physical therapy. They go through outpatient. They go through orthopedics, neuro, rehab, pediatrics, all these different things. Very similar to medical school, where you have these different clinical rotations, and then they specialize. When we're referring someone in this setting to physical therapy, it's going to be outpatient, orthopedic, sports medicine, physical therapy is what we're talking about there. So those are what we're doing when we're referring people for athletes and injuries. That's what we're doing. But what each physical therapist can do varies greatly based on the country they're at or the state that they're in here in the United States. In the US, they currently don't do any interventions like injections, but in other countries they can. But they can do other things like dry needling, joint mobilizations, soft tissue work, things like that. So there's plenty of things they can do that are hands-on and use different modalities in the United States, but they just can't do necessarily injections. And some physical therapists also can do imaging in terms of order some sort of imaging, whether it's x-rays or MRIs, so they can have those. And, it doesn't seem to be quite as common as seeing primary care do that, but they can do that. And another thing is some places also have direct access. So you essentially can book an appointment straight with physical therapy, not have to go through your primary care physician or clinician. And so that's just something to consider, the scale of physical therapy now. And the one thing is, if you've seen one physical therapist, then you've seen one physical therapist is kind of what I say. Just like clinicians and physicians, every one of them is going to have a different way of practicing, right? So they all go to different schools. Some have additional training. They've taken, weekend certifications or they did a fellowship or whatnot. So there's lots of variability. So that's just the first thing to understand is that when you see one person, you've seen one person, their experiences, what they've learned, how they practice. So it is not uniform I saw physical therapy because you saw one physical therapist, very different. But that's generally their backgrounds. They are the experts in rehab. And that's why we send people over to them because that's what their expertise are in. And so now I want to talk about why do people actually quote unquote fail physical therapy. I say I put that in quotes because a lot of times people haven't quite truly failed physical therapy yet. We're going to talk about the big reasons. Reason number one is adherence, right? This is the most important thing, is that most of the time we are not having the exact adherence that we're hoping for. Most people are going to get better with just even a little bit of help in terms of, hey, if you guide them in the right direction, they're probably going to get better. A lot of people just get better on their own, but most of the time, if we're sending physical therapy, you haven't. But most people just with a little bit of guidance will end up getting better. And so a wide range of problems can be addressed with a bunch of different ways, right? So there's a huge range of what these programs look like, but pretty much none of them will work if it's not done. And that's my biggest point is, when we aren't doing the program, that's not what we're going for. So the best written program is pretty much worthless if the patient doesn't do it. And I'm not putting this on the patient necessarily this is all their fault. I think a lot of times we'll say the patient's non-adherent, non-compliant. And that I don't think is very helpful because do I think ultimately a lot of responsibility falls on the patient? Yeah, I do. And I think that's important to empower them. But there's a lot of factors out there. Some things to think about is maybe the patient isn't bought into it, meaning they meet the therapist and the therapist says, hey, I want to try X, Y, and Z. And they're like, that's stupid. I'm not going to do that. And so they're just not bought into it. I think I'm a huge proponent of being bought in from a patient and clinician perspective at working together as a team to build a plan. Or if someone just tells you do this, it's not going to work. Same thing as a physician, right? If I tell you hey, I need you to do this, and you're like, oh, dude, I'm not going to do that, then it doesn't matter what I think is best for you or what may be best for you, but if it's not going to get done, then it doesn't matter. And so that's the first thing first. If a patient is not bought into physical therapy, then that's going to be a huge limiting factor for them actually adhering to the program and doing that. Another thing that may happen is the number of sessions. So someone might be like, this is way too frequent. I am doing way too much. A lot of times people unfortunately have seen maybe other providers who say, hey, you need to come back multiple times this week, then multiple times next week, and continue to do that for a certain amount of times. It varies depending on where you go. Some people say, yeah, twice a week for 6 weeks, or, once a week, or I don't know. There's just varying levels. Some people say it's too much. And then another reason could be the length of the session, meaning, hey, either in person, usually it's not as big of a complaint, but at home, they're saying, man, I'm doing like 30 to 40 minutes of exercises, and I just can't do that. It's just not reasonable. And so when people are also saying how frequently they're doing it at home, meaning, hey, they want me to do this like every day and it's taking me 30 to 45 minutes every day. I don't have time for that. That's one of the big things. So the main point that I was saying before, that it doesn't matter. The best written program is worthless if the patient won't do it. And so a lot of times we have to look into those variables. Another big variable here in America is the cost, right? Copays for physical therapy can be expensive. And I think, expensive is a relative word. It's not usually in hundreds of dollars per copay. That's, if you're doing cash pay, that could be the case. But for copays, usually it's not that much, but it's still expensive, right? If someone's on a fixed income, whatnot, can be a challenge. I hear that all the time from my retirees that like they can't afford the copays. I do believe that it's worth it. I think a lot of times I work with patients to say, hey, like I believe strongly in this, like this is a medication. You're paying for a medication to feel better. But that being said, it's tough. So if you have something you can't afford, right, and you're not bought into it, and you don't have time for it, like it's a recipe for disaster for why we wouldn't be able to adhere to this. And so when I say adherence is the number one issue, I'm not saying all the blame is necessarily on the patient just not doing what they're supposed to be doing. There's a lot of factors going into that. But if we haven't addressed that yet and let's ask that question, we need to ask that question. Number two reason that physical therapy fails is that there's no progressive loading. And this is actually my personal pet peeve. As mentioned previously, the vast majority of injuries are kind of a load management issue, meaning that, hey, when we're doing something new or increasing our running or we start a new activity, a lot of times that's what's a trigger for injuries. And so if load management is the issue, then load management is usually the answer as well. And so treatment should include some sort of proper loading that the patient can tolerate. And if you offload someone, that may improve their pain, right? So if you have them stop doing something, that's probably going to make them feel better. But if you haven't reintroduced it yet and set it up a way where you're going to progressively reintroduce that load, then we're not setting a patient up for success. So if you just say, hey, stop doing that, that's the general advice from most physicians. When it's like, hey, this hurts, like stop doing it. Okay, thank you. It's not very helpful at all. That's also one of my pet peeves. Clearly, I'm just being triggered by things, but that's one of my biggest pet peeves. If someone loves something, like if you want to lose respect from a patient, the fastest way to do that is to tell them to stop doing the thing they love. Classic example is runners. Runners are crazy in the best way. I mean that in the most endearing way, but runners want to run. Like that's what they do. And when they're like, yeah, I'm hurt in the run, you say, well, just stop running. You're just like, you might as well tell them to stop breathing, right? And so that's a big thing is telling someone to just stop is not the answer to a load management issue. It may be the answer for a short period of time. Like, hey, you're really flared up. We need you to stop for a short period, but then we need to reload them, right? We need to get that going and we need to do that. So that's number one, is like, that's not the answer. And then number two, a lot of times, no progressive loading. A lot of times patients will tell me that they did physical therapy and all they did was like passive stretching or other modalities and like something where they're not active. And when I mean active versus passive, this is really important. An active modality is where the patient is actually doing that activity, whether that's like they can do stretches on their own or exercises, like that's active. Whereas passive is something's being done to them. That is like, I, as a physician, do passive modalities, meaning injections, like that is being done to them. Dry needling, e-stim, stuff like that. Those are passive modalities. And so far too frequently, a patient tells me that all that happened to them in physical therapy was some passive modality and stretching. Like that's pretty much it. And there's a time and place for passive modalities, right? The passive modalities, scraping, electrostimulation, dry needling, joint mobilizations, assisted stretching. There is a time and place for all those things. And I'm not anti those things necessarily, but I don't think it should be the only component of a physical therapy program. Whereas active modalities, as I talked about, are self-stretching or strengthening, with strengthening being the biggest thing. And I always drive home the point that passive modalities have their place typically for like pain sensitization. When someone comes in and they're in a lot of pain, these passive modalities can be really helpful, but that's just kind of bring them back down. And then so we can help tolerate load and get them going. So if it's a load issue to start with, right, we've overdone something, we need to calm things down and then slowly build back up because we want to get back to that activity they were doing presumptively. So that's the big goal here. And, all physical therapy programs should include a discussion about load. I mean, if you are not discussing load, I think that's probably not right. We need to kind of, think about how it fits in the whole clinical picture, right? Passive modalities, once again, can do that, but have a plan to reintroduce load. And a lot of issues are tendon issues, and we know that tendons like load, but finding the right load is actually crucial. And so finding that dose, talking about it is really imperative. And when I talk about progressive loading, what I mean is that we're improving in some way, shape, or form. So progressive might mean increasing the stimulus in multiple different ways. You could increase the number of reps that you're doing in exercise, or increase the weight, or increase how long you're doing, activity for in terms of time duration, or even being able to do more with less pain indicates that you are advancing. And so these are all ways to increase stress and help the body adapt. That's ultimately the goal, right? We talk about all the time, rehab and strength and conditioning. It's all kind of on the same spectrum. It's like a seesaw. We have one here that's stressed, and then we want to react to it. We want to keep it in equilibrium here. And what happens is when we have too much stress going on and not enough recovery, then we kind of tip the seesaw in one direction that we don't want to go. But it's all about loading. It's really important. We have to kind of talk about that. And so when I talk about we should be progressive loading, that means, hey, the goal should be that we are building capable, functional people that are able to tolerate the loads that they want to do. So we have to start, if they can only do 2 reps of something or 2 sets of something, then we do that. And then the next one, try to do 3 and then work up to 4, whatever, and progressively load them so they can tolerate more and get them back to doing the things they want to do. And reason number 3 why they have not succeeded is they haven't given it long enough. Most conditions didn't happen overnight, so it's not going to get better overnight. And certain things have a predictable healing pattern, like fractures. Like fractures, say, hey, 4 to 6 weeks, the bone's going to heal, we're good. But a lot of our chronic conditions have a much more variable time frame, and it depends on a lot of factors. Things like your age, your activity level, whether you're quote unquote in season or not. When I mean in season, if you're an athlete or it's the summer season, that's the only time you can play pickleball outside, and you want to keep playing, like then it might take longer to rehab this because you're consistently irritating it while doing it. And I'm not saying that's right or wrong, just understanding, right? If you are dealing with an athlete who's in the middle of their season, it's really hard to rehab them because how do you manage their load of practice, games, and rehab? It's very tricky. And so all those things play into it. Age, obviously, the older you get, the harder it is to recover. Activity level is what are you doing day to day? Are you sedentary? Do you move around? All those things. And so that's something to think about in terms of having given it long enough. I say a lot of doctors will say, go to physical therapy, come back in 4 weeks if it isn't better. I mean, to me, this is just nonsensical. A lot of the times, it's one thing if it's an acute injury, right? Like, hey, something happened in 4 weeks. Like, yeah, we might feel a little better. But like people have had years of pain. You expect them to be better in 4 weeks? Like 4 weeks, that's insane. Like that is not a lot of time. Could we be making progress in 4 weeks? Yeah, I think that's reasonable that we'll probably see some progress. But a lot of times that's not the expectation that patients are given. They're saying, hey, I should be fully better in 4 weeks. And that's just not realistic. I say 6 to 8 weeks at a minimum before we can judge if you're even having success. And some things take even longer. I have struggled with patellofemoral pain, and I've been in physical therapy, previously a couple years ago for about a year, on and off about a year. Most people don't want to hear that, but that's the truth, that chronic conditions sometimes take a really long time to rehab, and it's really challenging. And so the biggest thing I can say I take home is like for my clinicians out there saying, hey, don't just set them up for failure, right? If you're saying you should be better in 4 weeks, that's what they're expecting, right? So we don't want to give them that narrative. Give them a realistic narrative saying, hey, this has been going on for a long time. You've had this pain for years. I don't expect it to be fixed in a matter of a couple of days or a couple of weeks. This may be a couple of months thing. That way we already have the perspective, hey, like this may take a while, and then we can kind of assess how we're doing slowly and not going to worry or think like, hey, I need to get this fixed immediately. So setting expectations is super important. And the fourth reason why people fail physical therapy is they don't have the right fit. Sometimes it seems like we're doing a solid program, but patients still aren't getting better. This is like when we have to reevaluate the situation. So the question is, do we have the right diagnosis? Should we have been treating it some other way? What haven't we tried? Oftentimes there's multiple ways to rehab, and they just may need a different approach. Like for patellofemoral pain, notoriously challenging sometimes for people to do it. Sometimes they work on hip strength versus quad strength versus working on ankle mobility. There's lots of different ways. And so sometimes you just need a different approach. Another question we have is, do we need another therapist, right? Just like people get second opinions all the time for physicians, it's reasonable to get another opinion from a therapist to kind of evaluate them. And sometimes that person has a better vibe. It fits with their treatment programs, or they just kind of have a different approach that works better for them. And so I tell people a lot of times finding a physical therapist is kind of like dating. Sometimes it takes a while to find the right fit. And people will shop around all the time for mental health therapists, right? Kind of find one that fits in the vibe. But I've never heard of someone saying that for physical therapy. Why is that? It's a very similar concept. You're finding someone who aligns with your values, your goals, and kind of gets you. And so unfortunately, I know insurance is tied into a lot of it, saying, hey, I'm only allowed to go here. And that's, I think, a lot of times why physical therapy fails is because people are saying, they went to this place and that's it. And that's all their, insurance will pay for. But just like finding that right fit for a mental health therapist or a physician, finding a physical therapist that works for you is invaluable. If you find someone you trust, it is like the best. And so that's something I recommend too. Sometimes we just need to reset, figure out, do we need a new fit? And so one thing I want to talk about here is how to assess if physical therapy is actually adequate. First question is, how long have they been doing it for? If they say, yeah, I tried, I've been to 2 sessions and I'm not better, It's not long enough. I will send them back and say, not rudely, but I'll say, hey, you know what? I think we just haven't done long enough. Let's give it a little more effort. So if someone says they want a couple weeks, then we got to continue with it. If they've done it for months and months, then okay. Then we kind of ask some more questions. Then we ask the patient what exercises they're doing. The reason I do this is twofold. There are actually a couple fold. Is first, it's going to give you a clue whether or not they know which exercises they should be doing. And once again, this is not an indictment to the patient. Maybe it was poorly explained by the therapist. Who knows? But if someone says like, oh, I don't know what exercises I do at home, that's a pretty good indicator that like they're probably not doing any other exercises. And so ask them, what they are, ask them how often they're doing at home. And then third, like ask them, specifically like, what are you doing in the physical therapy office? Are they talking about passive things or active interventions? And then also you can kind of ask them, hey, what has your progression been? Meaning, have they actually done anything? And so that's kind of when I'm doing that. So when I think about asking what exercises they're doing, I'm going to ask them specifically, what exercises they're doing in clinic. What are you doing out of clinic? How often are you doing them? And the big thing here is if they can't tell you any exercises they're doing, then I worry that they're not necessarily doing them. And then one advantage of getting assessed, you can kind of assess their progress as a clinician over time, right? So first thing is ask the patient, are you actually getting better with this? And if they say, yeah, then cool, that's great. But if you've seen this patient previously and they're at this level of pain, and then now you see them again and they're at a little lower level of pain, you can kind of be there to be the objective person and say, hey, like, that's great. Like maybe it's not as good as we want it to be, but we're definitely heading in the right direction. I usually say if someone's continuing to improve, I usually don't stop that in terms of like, okay, don't keep going to physical therapy, or like, hey, it's time for an injection. I usually let that ride out. I kind of explain to patients that there's like a slope of a line, right? Essentially, we think of how fast we're improving. If this is pain and this is time, if this line is very steep, that means we're improving our pain really fast. Sometimes the slope is a lot more shallow than we want it to be, but it's still progress. And sometimes they need a reminder that, hey, we are making progress. And like I said, progress can mean a lot of different things. It doesn't necessarily mean pain. Hopefully it is pain, meaning day to day. But some people are like, oh, I still have pain. You remind them, okay, well, when do you have pain? Well, it's only when I do squats now. Okay, well, you used to have pain with walking. And so just reminding them that like, hey, we're making improvement, and doing more with the same or less amount of pain is a big win a lot of times. And so the big things I think about here is how to assess this is, how long they've been doing it for. Ask the patient what exercises they're doing, are they being progressed? And then assess their progress to say, hey, are you actually making progress? And maybe not quite sure of it, but that's kind of what I think about. And so in summary here, physical therapy varies greatly depending on a ton of different factors, right? So every person is going to be different. Every physical therapist is going to be different. Every patient response is going to be different. So we have to consider that. When assessing whether or not it was adequate, think about, are they adhering to it? What are the exercise choices and progression, and how long have they been doing it for? And sometimes it takes a few tries to get it right. But if all else fails, then it might be time to think about other options. At that point, when you say, okay, you've been doing this for quite a while. You are adherent, you are determined with all your exercises, and it seems like a good program, then it might be time for a second opinion or do that. So this is just me personally, but if I'm going through rehab and I'm not having success, I think I'd probably do another consultation with someone else to get another opinion. And, specifically if you're like the next step is surgery, I'd be like, I would do a second opinion definitely before I get surgery. That's kind of how I think about it. But hopefully this was helpful to kind of determine how physical therapy works, how do we assess it, and can help you understand and have a realistic approach for not only counseling patients, but if you're a patient yourself, understanding what it's going to look like. And so this concludes the podcast. Thanks so much for stopping by. I really appreciate it. If you found today's episode helpful, and if you did, please, it would mean the world to me if you left a 5-star review on your podcast platform of choice, or if you share it with a friend who you think might enjoy it. And if you never want to miss a piece of content, consider signing up for my mailing list, which is linked in the description below. I'll send out content when I release it during the week, and I promise to never spam you because I hate spam just as much as you do. But that's it for today. So get off your phone, go be active, have a great rest of your day. We'll see you next time.